patient, you would see that there's different types of leukemias. Remember that you have acute lymphocytic leukemia, chronic lymphocytic leukemia, and you also have acute myelogenic or myeloid leukemias and chronic as well. That is depending on which lineage is affected. I told you before the break that we have two lineages in the bone marrow, myeloid and lymphoid, remember? So, for example, if the lymphoid lineage is affected, what you would see is that what is produced there, remember that you have lymphocytes B and T present there? So the patients would have affected either the production of antibodies or the cytotoxic presentation of the antigen to the immune system or the attacking portion of it. So T cells or B cells. So those are the lymphocytic portion. And the majority of cells that are present in a peripheral smear or the bone marrow biopsy will be high prevalence of lymphocytes, okay? Of course, immature. If the myeloid lineage is the one that is affected, the myeloid, if you remember when I explained it before, you have your erythrocytes, so the patients would have anemia. The megakaryocytes and megakaryoblast, patients are going to have low platelets and bleeding. Basophils and monocytes, this is mostly for phagocytosis, right? And cleaning after any type of inflammatory or infectious processes, so that will also be impaired. Eosinophils, so the patients will not be able to fight proper infections against parasites or any type of allergic reaction, and that's the reason why they get these flushes and rashes and all that. Have that in mind. So I want you to remember that whenever you have either eosinophilia due to high proliferation of mature or immature, not only is allergies, not only is parasite, but it could be cancer of the hematopoietic stem cells, leukemias, and lymphomas. Okay?
That's a hyperproliferation.
Hyper or hypo? Most likely hyper. Okay? Let me explain you why. Neutrophils, those also are affected in myeloid or myelogenic type of lineage, and patients can have neutrophilias and neutropenias, and I will explain that in a second, why either or, okay? And of course, the ability to fight infections is inappropriate, okay? And I said already about dendritic cells and monocytes, presentation is also affected, even though T cells have also the same purpose. Now, I'm not saying that if you have, for example, ALL or CLL, even though the lymphoid lineage, lymphocytes B and T's, are the ones that are most affected, and the patient's immune system presentation is affected, as well as infectious process are the highest prevalent of clinical symptoms on this patient, is not the only unique factor. They can have a combination of anemias and all that. But what is the most prevalent cell that is affected in CLL or ALL? Lymphocytes, okay? And therefore, if they're gonna have a higher severity of a symptom, that will be infection, because they're unable to present, they're unable to produce antibodies, okay? In the myeloid, even though, of course, they can also have infection because of the altered neutrophil count, the majority of the symptoms that they have is based on lack of overproduction of the myeloid lineage. And again, I will explain either or in a second. Erythrocytes, anemias, or polycythemia. Production of platelets, which is thrombocytosis or thrombocytopenia and bleeding. And if it's thrombocytosis, the highlighted code for thrombosis, okay, and clots. Eosinophils being elevated or eosinopenia and unable to fight infections based on parasites, allergies. And also infectious process is produced by either neutrophils, neutrophilia, or neutropenia. Why high, why low? Initial stages of myeloproliferative diseases, which is no more than the main name for all these type of cancers. What do you think the bone marrow will do? Exactly. What do you think the bone marrow will do first if they start perceiving that the production of cells is affected? Well, let me produce more. But it actually converts into a vicious cycle because I'll produce more, but I'll produce more immatures. And then those immatures get stuck and lice, and they're lost, and let me produce more. So the initial phases of these hematological cancers is a hyperproliferative stage. And patients are going to have lymphocytosis before they have lymphopenia. Patients are going to have polycythemia before they have anemias. Patients are going to have thrombocytosis, and maybe the only presentation that they might have clinically will be a clot before they bleed. They're going to have basophilia, eosinophilia before they have eosinopenia. They're going to have neutrophilia, and these are the patients that have a white count of 30,000, 40,000, 100,000, a million, and they're completely asymptomatic until it's depleted, and then they start having all the signs and symptoms. Do you understand? Good. Now, at the stage of hyperproliferation is when the patients tend to have the oncological emergencies. Even though I would not be able to cover this right now, and I will after the test, for sure, because I have another professor coming after me, so I have to finish. What do you think would happen if a massive amount of immature neutrophils, a massive amount of megakaryocyte platelets, a massive amount of defective cells of any kind, myeloid or lymphoid, try to pass through the catheter? The same thing as hemolytic anemia, right? So that, even though I'm not going to test you that right now, but after in the incoming exam, that would be a process of leukostasis. That's a massive amount of immature cells clogging the capillary, producing ischemia. How do you think it's going to get rid of? How can you get rid of that? Chemotherapy. It's the only way. Okay? Or plasmaectomy as an emergency. Okay? Now, the most common, if that oncological emergency doesn't happen, then of course the patients will present mostly with infectious processes due to lymphopenias, right? The patients will present with anemias, thrombocytopenia, and bleeding. The patient is going to present with eosinopenia, infectious processes. Now let me tell you briefly another oncological emergency. What about if you start breaking and breaking and breaking platelets? Isn't platelet the first tissue factor that triggers the coagulation cascade? Mm-hmm. So what happens when you constantly activate the coagulation cascade? DIC. So that's another oncological emergency that these patients will have. Okay? Common sense.
Still experience like a vaso-occlusive crisis without having history of ever having a hemolytic coronary symptoms, like whatever, they will present with them.
And they can go through polycythemia vera as well, meaning that this is the same as aplastic anemia that the patient have pancytopenia. Polycythemia vera is no more than all the lineages are increased. And what's the consequence of that? Having high amounts of erythrocytes, a hypercoagulation, hyperviscosity, and clotting. Right? So, if we have the myeloid lineage affected, not only we'll have myeloid leukemias and acute versus chronic, if we have the lymphoid lineage affected, which are the lymphocytes, T and B, not only we can have leukemias of the chronic lymphocytic leukemia, acute lymphocytic leukemia, but when that lineage is also affected, we can have lymphomas. Okay? Now, plasma cells is another type of hematopoietic cell that is also along with the dendritic cells and the monocytes and the histocompatibility complex, which is part of physiology, that present the antigen. So when the plasma cells are affected by a malignancy, that produces a plasticytoma, which is a tumor of the plasma cell producing multiple myeloma, and we'll go there. Okay? So again, what are the classifications of leukemias depending on the cell lineage? The most common presentations are acute versus chronic. So lymphocytic, that I want you to remember that word, acute versus chronic. As I said, when the lymphoid lineage is affected, not only you could have lymphomas, but the plasma cells are also affected. So not only lymphocytes T and B, but also plasma cells. So multiple myelomas are present there. Myeloid lineage, acute versus chronic. We're going to go in detail in a second. And what else could happen? When the myeloid, if you have high erythrocytes, that's erythrocytosis. That means that hemoglobin is elevated, right? So if you have elevation of neutrophils, if you have elevation of platelets, and any other type of etiology that can induce myeloproliferative state.
Oh, so the location one.
Yes. So it's a huge paragraph, but acute myeloid leukemia. Acute myeloid leukemia, first of all, I want you to remember the M. The M is for middle age. Okay? So, most commonly in middle age, some book says 50 to 70, other book says 40 to 50, it doesn't really matter. Okay? The major difference is that chronic versus acute, of course, the patients go through a major crisis compared to more benign event, right? And more maturity that is achieved in the chronic versus in the acute. In the acute, you're going to have more presence of immature cells and blasts, and therefore more complications, right? Remember that the myeloid lineage are your red blood cells, anemia, thrombocytes, thrombocytopenia, bleeding, right? Neutrophils, neutropenia, and infections, right? So even though the other lineage could be affected, the most common lineage that is affected is RBCs, platelets, neutrophils, eosinophils. Okay? So all leukemias would have an oncogene. If you remember patho, remember that you have a tumor suppressor gene that doesn't allow you to get cancer, and an oncogene that when it's mutated, you get malignancies, any malignancies. So you will read in your books that there are many, many translocations attached to chromosomes, and that's the reason why the patients get these cancers, okay? I will tell you which one exactly you need to know. All right, so basically this here, all major paragraph that is for you to read, that because the myeloid lineage is the one that is affected, the most common clinical signs and symptoms that the patients will present with, even though at the beginning it's a myeloproliferation, and they have erythrocytosis, thrombocytosis, eosinophilia, when the patients develop symptoms, because at the beginning they're completely asymptomatic, unless they go through an oncological emergency, they will present most commonly with anemias, bleeding, and infections. you to remember the word blast. And blast is no more than if you go again through the cascade of the hematopoiesis, all the immature cells. When you do a peripheral smear, when you do a bone marrow biopsy, what they see in that microscope is only immature cells called blast. So they're not going to have basophils, neutrophils, eosinophils. They're going to have erythroblast, myoblast, and all that. Immature formations. Okay? So here is another form, because if I keep going, wait, well, it's later on. If I keep going through the classification, okay, you will have one classification for each type of blast. Okay? So if I come here, the one that is completely immature, I am going to have, imagine the megakaryocyte, the platelets, okay? That you have thrombocytes, you have megakaryocytes, megakaryoblast. So you would have, for example, acute megakaryoblast anemias, and in the case of leukemias, acute megakaryocytes. When you have 3 or more cellularities being affected at the same time, it's called promyelocyte leukemia. Prognosis is worse, and mortality is worse. Okay? So basically, having an arm of a gene mutated stick to another. This is more than what you should know. For example, ABL gene with a CRL gene, they get stick together and they produce a worse mutation. Therefore, having acute promyelocyte leukemia is a worse prognosis than having only ALL or CLL or AML or CLL. It's a combination of. The more mutation, the more probabilities of mortality, prognosis, and curative rate will be worse, right? And of course, the more probability for oncological emergence to be the first initial presentation. Well, all the leukemias are due to translocations of a proto-oncogene. But here, now there's a fusion of 2 genes translocated, which of course makes the prognosis worse. Okay? So, this is basically what explains here. So, as I said, just look for middle age, okay? So, your,
middle age,
well, it's acute, well, I mean, 50 to 70, the book says 50 to 70. Yeah, well, I'm very young. So even though this type of cancer, anybody can have it, unfortunately, Europeans, Hispanics, higher risk for having it, okay? And what are you expecting, again, the cellularities, and I keep emphasizing it because this is fun. What? In myeloid, red blood cells, platelets, neutrophils, right? And therefore, which is the type of cell that you're going to be looking for in the peripheral smear? Blast. Okay? So yes, the patient's going to have anemias, leukemias, thrombocytopenias, and therefore, infections and bleeding. Signs and symptoms. If you have anemia, signs and symptoms of anemia, right? Fatigue. You do have shortness of breath. Why? Because the hemoglobin is the one that transfers the oxygen molecule. Therefore, you feel short of breath. Easy bruising, petechias, purpuras, gum bleeding, very common. Okay? Or epistasis. Patients can have that. And again, infections and anemias. Now, why? Oh, some patients, let me tell you as well, how do they present. night sweats, mild fever, and loss of weight. Okay? Now, why do the patients have bone pain? Why do the patients have splenomegaly? And because remember, the secondary lymphoid organs are actively working to be able to compensate the deficit of the bone marrow. And when the bone marrow is in hyperproliferation, that hurts. Gingival hyperplasia. Remember that your tonsils are lymphoid organs. Your alveolar patches of the intestines are. Okay? So the gingiva becomes hypertrophic, not only easily bleeds, but becomes swollen. So that's called gingival hyperplasia due to infiltration of immature cells at the level of it. So that's the reason why very, very common that they come in with gingival bleeding through brushing or epistaxis through the nose or mouth bleeding. Petechias, purpuras, remember these are non-blanchable lesions. Now, these clusters of immature cells not only can be stuck in the capillary, but also can be stuck at the exit of the bone marrow, producing a tumor that is called myeloid sarcoma. Okay? As I said, risk factors, we already went through the cultures, and it's present in middle age. Smoking can induce it. Chemotherapy for another cancer can induce it. Benzene can induce it. Working close to industries and having toxic fumes around it, or in the water, can induce it. In addition to having an autoimmune condition, induces another autoimmune condition. Having one cancer induces another cancer, which is called Men's syndrome. You're going to study that next semester. And having a genetic translocation induces another genetic translocation. So patients that have Down syndrome not only can have congenital cardiac disease, intestinal, but also bone marrow deficit as well as malignancy. Okay? So, for example, I don't know how I'm alive, but when I was in Cuba, we used to drink water. We used to go to school in the morning, and in the afternoon, we used to do agriculture activity. We had no water to drink, so I am honest, I had to go into the sprinkling thing for the plants, or the, I don't know how you call it.
The irrigation system, yeah.
That is full of pesticides and herbicides, and we had to drink that water and even eat whatever was produced to be able to feed ourselves. So pesticides, herbicides are toxic for these conditions. Now, even though there is a criteria based on cellularity, just for your knowledge, that is called FAB criteria, or another classification that is called WHO criteria, that is an overwhelming criteria based on which specific cell in the lineage is affected. I'm just going to show it to you. What's the most prevalent cell that is present in leukemias? Blast.
Having a blast.
Look at the classification, for example, FAB. Look at the classification. Well, it could be completely undifferentiated. Why? Because as you're having through a hyperproliferative state, everything's high, so you have no idea if it's inclining to the lymphoid or the myeloid. Well, now it's having myeloid without maturation, myeloblastic with maturation. Most likely this is CML, because chronics tend to be more close to maturity than acute, right? Pro-myelocytic, myelomonocytic with your eosinophilia. As you can see here, this is basically which exact cell and which stage the patient's present, right? The more cellularity affected, the more probabilities of mortality and the stage that the disease is present and treatment is attached to it.
This is only for our knowledge, right?
Yes. Another classification, well, this is exactly the one that I just showed to you. Another classification, again, is the WHO, but you need to be familiar that it exists, right?
Yes.
WHO classification, look, how many translocations can exist? How can you do that and analyze that? Chromosomal, genetic studies is the only way, right? So if you're actually able to do a genetic study and you have a translocation on 8 and 21 or chromosome 16 or 15 and 17, blah, 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 you got a classification, right? Or the entire lineage is dysplastic or is undifferentiated. So this is a combination of WHO and FAB, and depending on the stage that the patient is, the prognosis improves or deteriorates and the treatment is attached to it. You should imagine that the lower the stage in M0, 1, 2, etc., these patients up to here at high probability of getting 70 to 80% cure in induction only, versus getting resistant, and you might need a combination, versus needing transplantation. Classification. Chemotherapy. Even though there are many, okay, and even though we start with rituximab, which is a tyrosine kinase inhibitor, what's the principle for any cancer treatment? You do induction therapy first, which is also called remissions phase 1 and 2, okay? So you do induction therapy, deplete the immune system, and then you try any type of curative and maintenance. Do you understand? Okay? And adjuvants, you could do radiation therapy, and of course the curative, only curative is bone marrow biopsy. But you will see in any book that you read that patients can achieve, and let me tell you, age is a significant factor. Age is a significant factor. If you're lower than 65 years of age, some books says less than 70 years of age, the probability of going into an induction therapy and going to remission within the first or second year of treatment is high compared if you're more than 70 years of age. And your probability of having resistance to one treatment and going into combination and full chemotherapy or failure and going into bone transplantation is also higher if your age advances more than 7 years of age. So not only the stage of the disease is a factor, but the age of the disease is a factor. So please, induction therapy first, and then curative or maintenance. Examples! Besides the tyrosine kinase inhibitors we talked about, what can we do in induction therapy? What can we do? And tricycling, right? Examples of that are those. I don't even know them myself. Cytarabine, okay? Basically that penetrates more, and because it penetrates more to the CNS, patients can have more complications. I mean, these medications can induce acute kidney injury, liver failure, CNS disorders, infections, overwhelming. So patients cannot. And as I told you, the lower the stage, the lower the age, the most probability of achieving remission. In the first to second year, that will be 80%. Post-remission therapy, meaning that once you provoke an induction, the newest generation, as I told you now, is not in your PowerPoint, but it's this tyrosine kinase inhibitors we talked about. rituximab. Post-remission therapy, which is no more than your consolidation therapy, that you can give lower amount of chemotherapy or combination therapy, or go straight to the curative, okay? So, examples, cytarabine, and you could also do, for example, globulins, you could do prednisone.
Wait, hold on.
Yes.
Can you go back to the other slide? The post-remission therapy is what you do. Everybody who has induction therapy does post-remission?
No.
Because you
No.
may get better.
Sometimes if you achieve remission in the first, let me tell you, many patients, depending on the stage, and you will see it in the phone. Let me give you an example of a family member. My sister-in-law, she had Hodgkin lymphoma, and her stage was 1, only a lymph node in the neck. She received radiation therapy. She only received 3 dosages of induction therapy, and she achieved remission in 3 months. That's it. That's it. Only follow up PET-CT, and after a year, clean, pour out. That's it.
Remission meaning that it's out, that it's finished?
Remission. Well,
You're in the clear.
now, you're in the clear stage, meaning you could have a 20% chance of coming back. And if it comes back, that could be a question, general like that. If it actually comes back, your prognosis is poor.
Yeah.
Poor. Okay? So there's only a chance of 20% of going into active stage. And after that, you need more aggressive therapy, so combination therapy or transplant, but not even insurance is approved if you go back.
So after the induction, your sister went to the post-remission therapy, which is like the lower
If it's
dose.
necessary.
It is necessary, so not every patient. is
Now, if
gonna
a
do it.
patient fails induction therapy, you assume that there is resistance, right? And you could do a combination therapy, okay? You could do full dose consolidation therapy, or go straight to transplant, okay? But only if the patient fails. Or you see that, because how can we monitor this patient, in this particular patient? Blast. So what are you assuming? That the amount of immature cells is going to go down, the amount of maturity cells are going to go up, right? So if the amount of blasts decreased, the patient is improving, right? Symptoms are improving, so you're in the right direction. Continue therapy. You can continue for 3, 6 months, a year, 2 years, depending on what the patient needs. You're not going to change to combination or others in consolidation state if it's working. Okay?
Don't,
I know it's confusing, I know.
no, don't they say that the chemotherapy also kills the good cells?
Yes, but because the chemotherapy also kills the good cells, here's the complication. Patients can have anemias due to chemotherapy as well. Patients can have infections due to chemotherapies as well.
But it will be,
You have to deal with the complications. So that doesn't mean necessarily, if you look at the peripheral smear and you have less blast and the patient's bleeding, maybe the aggression of the chemotherapy to the platelets, but you can see that the patient has megakaryocytes instead of megakaryocytes. You understand?
yeah.
How often do they do the peripheral smear?
Or every 3 months, or more if it's necessary. So, what is the goal? What do you think is the goal? Which is a question. What do you think is the goal for any type of induction remission or curative therapy in this patient? What's your purpose?
Increasing mature cells.
Increasing the platelet count for the patient at least to 100,000, right? Neutrophil count less than 1,000. These patients can go into 1 million. This patient can go 500,000, 20,000, 30,000. As I tell you, this is a walkie-talkie bomb. You see a patient, if you ever see a WBC more than 20,000 and the patient has no signs and symptoms of infection, think about a malignancy first, okay? And also in the bone marrow, the amount of blast should be 5% or less. So if you start with a 30% of blast and then you do peripheral smear and you see 20, 10, 15, it's working, right? So keep it. What else can you do? To be able to see the translocations, not only genetic studies could be done, but also you could see, you could do a protein chain reaction or flow cytometry to be able to see which type of proto-oncogenes the patients have active. Okay? So this patient has a WBC of 18,000, not that bad, right? Hemoglobin is 13, so anemias, leukocytosis, NCV, NCHC, NCV 88, so normal. NCHC 32 to 36, normal, so normocytic, normochromic. Platelets 215,000, remember is? To 450, to 450, yeah. So this is normal still, okay? And now let's look at the amount of cells, okay? Basically what's affected is bandemia, so the patient has 22, which is the left shift, very common on them as well, highly confused with an infectious process, and lymphocytes, okay? 3 from 20 to 50%, lymphopenia, okay? Yeah. Now, this is a very, very, not normal. Of course, it's not normal. This is a very bad example to be able to differentiate a patient with infectious processes versus leukemias. But let's imagine that I tell you that the patient has leukemia. Tell me which type of leukemia this patient most likely will have. Would it have a myeloid lineage or lymphoid lineage? Lymphoid. Please look at, even though again, the patient has anemia, even though the patient has anemia, the patient most affected cell would be lymphocytes.
And even though, I mean, we're looking at supposedly that tumor cures would be greater than 20, it would be worse if it was like greater than 30.
Now, if you're in the first phase, you're going to have lymphocytosis. And in the later stages, you're going to have lymphopenia. Okay? Now, does it mean that you're not going to treat this patient for an infectious process until proven otherwise? You have to. You have to. So that's the reason why the majority of these patients are highly confused with an underlying infection. They get all these type of exams. You're going to see also in the next classes. We have a presentation of fever of unknown origin. Whenever you have fever and fever and fever and fever and fever, even though the most common cause of fever is in, that's my son. Even though the most common the most common etiology of fever is infection, you must rule out malignancies. Okay? Because these are the patients that you treat infections, you can't find the source, and they continue to have it, the fever, in this case, and the leukocytosis, okay? And mostly, as I told you, if you see a patient with a high WBC, 20,000, 30,000, 50,000, 100,000, and the patient is like that, normal, think about cancer to prove it otherwise, okay? So, CML, chronic myelogenic or myelocytic leukemia, same, middle age. The major difference is that acute have a higher probability of presence of blasts, even though clears too. But since the patient has had this disease for many, many years, the bone marrow has been able to adapt, right? More than the acute episode. And the cellularity, the immaturity will be highly present in acute versus in chronic. And even though the patients would have also blasts, they would have a high percentage of maturity compared to acute. That's it. In addition, even though acute myelocytic leukemia, they do have translocation, as I explained to you, in chromosome 8, 11, blah, blah, blah. The most significant translocation in chronic myelocytic leukemia is called Philadelphia chromosome. Okay? So, that is the cytogenetic hallmark of it. Okay? Now, in addition, have you seen the BRCA and the fusion of the BCR ABL in breast cancer is also present in CML? Okay? So, yes, middle age, as I said, 50 to 70 years of age. This has a better prognosis than AML. And of course, higher survival rate. Let me open everything. So, in CML, what cellularity is affected? Same as AML. Myelogenic lineage. Anemias, thrombocytopenias, right? And infections, so platelet, yeah, thrombocytopenia. But of course, the presentation is later compared to acute. The prognosis and the severity is lower compared to acute. They won't be able to fight properly and macrophage and fight infection, as I said, the same as acute, but it's just the presentation. I told you that even though the most common translocation is Philadelphia chromosome, they have many other mutations. The BRCA, right? The translocation of chromosome 22. What do you think you're going to get it on the test? Philadelphia chromosome. Okay? So, the majority, as I said, since it's a chronic stage, they come asymptomatic. They don't realize it's just an incidental finding that they come to do annual exam and you see a WBC in the 35,000, 50,000 with no signs and symptoms of infection. Okay? Or you see patients with thrombocytosis in the 500,000, 700,000. Whenever you see thrombocytosis, it could be reactive, but rule out cancer first. Okay? Or they come in with only mild fever, nice sweats, lost weight. They can come in with abdominal pain. Why? Right upper, left upper, splenomegaly, hepatomegaly. Okay? Bloating, sensation of satiety. And of course, when platelet is already affected, petechias will rise as well. Philadelphia chromosome, don't forget that. Okay? So as I said, it's an incidental finding. CML, most of the time. They don't have any symptoms until late. Now, how can you see this translocation? Besides genetic studies, you could also see it if you do, for example, PCRs and fluorescent immuno something. It's called FISH. Okay? And of course, the clinical signs and symptoms. So, treatment. Reduction, right? Consolidation, curative. Same way. So, basically, if you have a patient with, because CML, since it takes so many years to show show symptoms, sometimes the patients do a blast crisis. And that could be their only presentation first. So if it's so, you have to do an aggressive induction therapy in these patients, okay? And in the chronic phase, if you see a patient with, believe it or not, even though no treatment can induce a blast crisis, if the patients are asymptomatic, okay, and there is fewer than 10% of immature cells on plasma, there's no need for therapy. It's contradicting. That's what the guidelines says.
Say that again.
Because it's only less than the percent.
Is that the
The
one?
guideline says that even though no treatment for CML can induce blast crisis, if the patients come to you with a 10% blast, which is immature, in plasma, there's no need for therapy until there's more than 10%.
You wait till 6.
Yes, unfortunately.
So when you would wait until they were 20 or 30, like above 20, as per like the other guideline or whatever, the whole guideline.
Just sit there.
Why? Because the benefits of is more the benefits of putting the patient on remission when the patient has no symptom, okay, is worse or higher risk than putting the patient into complication. It could prevent it, but if the amount of immature cells are so low that the chances of them going into oncological emergencies and crises are very, very low as well. So you're going to produce more damage due to the complications than benefits to the patient.
And then you can't go back.
Exactly, exactly. So once the cellularity goes higher than that, like 20%, patients are high risk for fulminant symptoms or blast crisis. So what can you do? Examples. As I told you, everything that we have said is old, new generation thyroxine kinase inhibitors, which are your Rituximab, many other names, right? Rituximab is the most common that is used. And of course, curative transplant. This is the way they work. I'm not going to ask you mechanism of action or anything. All right? This is one by one. How do they work? I need to. Now, CLL. We ready the AML? CLL. I'm sorry, CML. Now, CLL is also chronic, late onset of symptoms, good prognosis, 50 to 70. That L in medical school, L in Roman numbers is 50. And if you add a C or another L, it's to 100. So 50 to 100, 50 to 80, depending on the book that you read. Okay? So you need to get a mnemonic. Okay? So L is lymphocytes. So these patients are at higher risk of infectious processes. They are more likelihood to have T cell deficiency and antibody production deficiency. It is B or T. Okay? So you diagnose it exactly the same way. And what will you see on the flow cytometry or peripheral smear? Lymphocytes.
Oh, lymphocytes.
And even though I keep emphasizing it, you lose it. Clinical signs and symptoms, mostly infections, right? And they also have lymph organs secondary participating in it, so they would have splenomegaly, hepatomegaly. Are the reticulocyte count increased? No. Good. So deposits of the amount of lymphocytes immature at any level. Remember that it could be in the bone producing sarcomas. It could be in the lymphoid organs secondary, the tonsil, Okay, the wall-layer patches of the intestine, so patients can have hyperproliferation there as well. So what would be the laboratory results? Even though they could have anemias, thrombocytopenias, etc., the same as myeloid, what would be the most relevant cell? Lymphocyte. Of course, initially will be hyperproliferation, lymphocytosis, and then lymphocytopenia. All right? How do you diagnose? The gold standard for any of this is bone marrow aspiration or biopsy, right? What else would you do? Well, you could do such as genetic studies, you could do electrophoresis, you could do peripheral smear, basically to diagnose either the translocations or the cellularity that the patient will have present, right? Either the myeloid lineage or the lymphoid lineage, okay? So, as you can see, CLL has another group of translocation, which are not relevant, but not relevant. So, chromosome 13 and 14, 21, so they can induce down can induce them. Okay? Now, of course, you're not going to have the features of Down syndrome already when you're an adult, but you could have mental retardation due to the translocation of that chromosome. Okay? Classification of CLL. Their classification is called a Rye classification. If you look at the classification, well, here only has lymphocytosis. This is for your FYI. Lymphocytosis with lymph nodes enlargement, with splenomegaly or hepatomegaly, with anemias and everything else, with thrombocytopenia and everything. What I'm telling you is that initially it's only lymphoid, and then affects the other across. You could imagine that up to here, good prognosis, higher chances for induction and remission after induction therapy, 3 months up to 2 years, more chances of curative and not coming back, worse prognosis, and high mortality. Okay? Another classification, and treatment is the same. Alright? So other combinations that you can use that exist for all therapy, chlorambucil, you could use prednisone, you could use methotrexate even though it's for autoimmune conditions, and other types of combination of thyroxine inhibitors. Radiation therapy, monoclonal antibody, splenectomy, we already mentioned that, right? Or stem cell transplant. Lymphomas. We have 3 types of lymphomas: Hodgkin, non-Hodgkin, and Burkitt. Okay? What are lymphomas? Tumors of the lymphoid lineage. So what's affected here is lymphocytes B and T. And these patients are unable to defend, the immune system is unable to defend or present the antigen, so it's not recognition. Plus, the amount of antibody produced is affected, so infections. So, you can read that. Hodgkin lymphoma. Okay? Let me tell you, let me tell you what happens here. Patients with Hodgkin or non-Hodgkin lymphoma, since what's affected is B cells or T cells, the B cells are produced not only by the bone marrow, but also by the lymphoid lineage, where you have all your chains of lymph nodes. Okay? So the most common you have lymph nodes peripherally and centrally. So, sir, you remember health assessment? So, pre-auricular, post-auricular, right? Your superficial cervical change, deep cervical, occipital. You remember that? Supraclavicular, you don't have to do that in the company. Supraclavicular, infraclavicular, unless you're thinking about this, right?
No.
Supraclavicular, infraclavicular, axillary, right? Inguinal, those are peripheral. But what about mediastinal? Peritoneal, which are abdominal. These patients most commonly present with a lymph node enlargement. Most commonly one. Most commonly one, most commonly unilateral, most commonly peripheral. So this is a patient that, and that's exactly what happened to my sister-in-law. This is a patient that suddenly sees a neck mass, non-painful, non-movable, without any other type of symptom. The majority associate this with maybe I had a viral condition before, but it's not going away, and it's not hurting me, right? As the condition progresses, and you will see that classification you need to know, as the condition progresses, of course, the lymphadenopathies take over, not only above the diaphragm, but also in another, not only unilateral, but bilateral, and also metastasize to other organs. So the majority are asymptomatic at the beginning, and because of that, they don't seek medical attention quick enough, okay? And some practitioners, like the one she went to, oh, that's an infection, let me give you antibiotic, and oh, let me send you to the ENT, and chain of commands, and everybody fell too. But it was obvious, it's 2 + 2. The mother, and this is another factor, family history of hematopoietic cancers. A mother with leukemia, she comes with the lymphadenopathy. Of course, your family don't believe you, ever, right? You do a diagnosis in your family, they don't pay attention to you. Isn't true?
Yeah.
I told her, Ruby, what? Your mother had leukemia. I don't want to scare you. You must that checked off because you have to rule it out. And months and months and months, when actually was diagnosed, stage 2. But good enough, it was very, very small in the mediastinum, so it went away with induction therapy. So that's the reason why they don't seek medical attention quick enough, because it's asymptomatic. Now, since I mentioned you that all these cancers have a translocation, and CNA, Philadelphia chromosome, right? Reed-Sternberg cells are the pathognomonic translocation for these patients. How do you think you diagnose this patient? The only way to diagnose this patient is lymph node biopsy. If it's in the mediastinum, you could do little biopsy, right? Or you could do what? Open lung biopsy if it's present in the lung. We have done that. Okay? And treatment, of course, is chemotherapy, radiation therapy, up to the point of bone marrow transplant.
Dr. Leal, are the lymphomas genetic? Like, are they passed down?
They are. Yes.
Are they what?
If this passed down into generation, once you have a translocation, you could inherit that translocation. Okay? So, let me tell you, Hodgkin lymphoma is the most common benign compared to non-Hodgkin lymphoma, which is the less prevalent, but is the more aggressive and more malignant. Survival rate for Hodgkin lymphoma is super high. Survival rate for non-Hodgkin lymphoma is very low. This patient, least likelihood for induction, remission after induction. They most likely have to go through combination, full dose chemotherapy, radiation, and even up to the point of bone transplant if they survive. Okay?
Can they go straight to bone transplant?
They will reject quickly. Okay, but yeah, it could be a plus. Now, remember that doesn't mean that the lymphoma is going to give the patient HIV. Listen to this. No. But if the patient has HIV, what do you think is going to happen to the patient? Prognosis is worse. Because they also have translocation by itself, right? The virus transforms and mutates quickly. So, rate of not survival only, but the therapy for HIV to work properly is really low. Okay? Remember that these patients, if they have had hepatitis B in the past, the same as the other conditions that I have explained, they can have a reactivation, so you must vaccinate them for that. And, you know, of course, they do not have Reed-Steinberg cells. Hodgkin lymphoma, more B cells affected. Here, that's the reason why they have a poor prognosis, not only the B cells, but the T cells, and everything else is affected. Same treatment. Now look at what can induce leukemias from virus. Chemotherapy due to another cancer that the patient is going through. HIV can induce cancer, not only sarcoma, Kaposi sarcoma, but they can induce leukemias and lymphomas and Burkitt's and multiple myelomas and other type of cancers, okay? Because the immune system is highly compromised. We have seen that H. pylori is not only associated with stomach cancer, but H. pylori can induce Men's syndrome, multiple endocrine neoplasia syndrome, as well as a type of lymphoma, which is called MALT lymphoma, highly aggressive. Wow. So treat your H. pylori. I'm waiting for my result.
Is this the etiology in general or under the umbrella?
No, yeah.
In
It's
general
been tested.
Cancers.
Yeah, okay. It's been tested that induces cancer. Not only stomach cancer, which is the highest incident, but any other cancer.
No, but I'm asking if the etiology, like that PowerPoint slide, is just
General,
okay.
for any cancer. Okay? So as you could see, look at the translocations, which I'm not going to be specific, only on the ones that I told you, Philadelphia, and the Reed-Steinberg cell. Okay? And who's also a higher risk environmental-wise? What about me drinking the water full of pesticides? So farmers and agriculturists, if you live nearby an industry, right, that the water or wasting are put into the river and all that, and you fish there and you eat the fish, right? Another major classification, again, this is also a WHO classification. No, this one is not important. I mean, it is, but no. So as you can see, if it's only the precursors affected, it has a better prognosis than if you have mature cells affected. Even though CLL has more mature, better prognosis, but when it's combined with another translocation, decreases the prognosis. Okay? No, not that one, not that one. No, not that one. Another classification based on clinical presentation. Well, if you're completely asymptomatic, you believe that the prognosis is better, right? Because if you have no symptoms on one lymph node, compare that of having across the line or below the diaphragm metastases. Or two, and patients having anemias, thrombocytopenias, infections, etc. So that's called indolent, okay? Versus aggressive, you could imagine that that patient has metastases. Okay? So, diagnosis. You could do hemoglobin and hematocrit. You could see if the patient has anemia or not, or any type of infections based on WBC, right? You could do chemistry, because remember, the same as leukemias, lymphomas is a hyperproliferation initially of immature B cells, T cells, getting together, producing the same symptoms of leukostasis. Okay? So, if leukostasis takes place at the level of the renal artery ischemia, acute kidney injury, bilirubin creatinine is elevated. The breakdown, right, of the immature cells, not only hemoglobin, but also any type of cellularity in the hematopoietic system can induce to what? Elevation of urea, elevation of uric acid, right? So patients can have gout, right? Electrolyte imbalances due to calcium if the bone is affected because it's hyperproliferative, right? Having hypercalcemia. So you can see that in your chemistry. What is LDH? Why LDH will be high in these patients as well? Cluster of immature B and T cells, right? In this case, remember, it's the lymphoid lineage, so they would have lymphocytosis as well, even though it's not CLL or ALL. Okay? So, what do you think the patient is, or the cells is going to feel? Ischemia, hypoxia, then anaerobic, lactic acid being released, right? Diagnosis, specific tissue biopsy. What will you do? CT scan of the chest, CT scan of the abdomen, not only to look for metastases, but what about lymphadenopathies in the mediastinum or in the abdomen? What will you do PET-CT to see if it's spread out? Not only initially as a staging, because once it's diagnosed, you have to stage the patient to see which type of route of treatment you're going to choose. But in addition, PET-CT is not only prognostic factor and guidance of treatment, but also to see if the treatment is working properly. Because you do an induction therapy first, or chemotherapy and radiation, and let me look at the PET-CT to see if the nodules are shrunk, right, or have disappeared. So, and what will you do lumbar puncture and analyze the CSF? Neurological symptoms, but as well, you could see the same cellularity in the CSF, okay? This classification you must know, which is called Ann Arbor staging system. Let me show you the picture, which is better to understand. The picture is easy. Stage 1, the most common presentation. Patient is asymptomatic. Patient has one nodule above the diaphragm. Non-painful, non-movable. Stage 2, 2 nodules. Now, what about if the nodule, instead of being in the same side, is on the other side? Stage 2. I know that question was coming. But it's still above the diaphragm. Okay? Remember, it's important to know if it's above or below. Okay? Stage 3, forget about this. It could be 2, 3, whatever. What about if you have 3 here, 4? Still stage 2. Still stage 2. Because you don't have nothing below the diaphragm. Stage 3, you have above and below, but there's no metastases to the organs.
What do you know you're lighting up the spleen?
You can have splenomegaly, but that doesn't mean you have cancer in the spleen. What about if you have one here and one here? Stage 3. What about if you have 5 here and 1 here?
Stage 3.
What about if you have 1 here and nothing here?
Stage 2.
1. you have 5 here and nothing here?
2.
And metastases? 4. Good. Same explanation. As you could imagine, the lower the stage, the lower the risk, the higher the stage, the higher the risk. Okay? Same treatment. Multiple myeloma to finish. Multiple myeloma is the cancer of the plasma cells. Remember that for the myeloid lineage, which one do you have? You have the aplastic anemias, you have the AML, the CMLs, right? And all the myeloproliferative disorders. For the patients that have lymphoid lineage, you have the CLL, ALL, which we didn't cover because even though it could be present in adults, it's most commonly in children, 3 to 7 years old. And that's the one that you would not wait. Even though they do induction and all that, if the patient first presentation is really bad, they go for everything to try to save that patient because it's a child. Okay? So ALL, CLL, lymphomas, and plasma cells. So this is also lymphoid lineage affected. Plasma cells are the one in charge of plasma dendritic histocompatibility complex, and monocytes present the antigen to the immune system. So basically, again, it's no more than a malignant cell, growing tumor at the level of the plasma cells. So the immune system is unable to present the antigen and starts to attack. Now, the most common presentation for these patients, even though, yes, infection could be one, they have a typical laboratory, radiologic, and clinical presentation, okay? That you can summarize as CRAB, C-R-A-B, okay? So even though, yeah, exactly. So C for hypercalcemia, 11.5 or more when it's a total calcium, and you have ionized calcium more than 2.75. R of the crab for renal insufficiency. Makes sense that, first of all, you have a huge amount of plasma cells getting accumulated at any level, right? Not only will induce uremia and uric acid and gout, right? But the nephrons cannot be perfused properly and the patients go into renal failure, despite the fact that hypercalcemia can induce lithiasis, nephrolithiasis, and renal failure, okay? So you get it from 2 points of view. A for anemias, even though the myeloid is rarely affected. And B, because there's so hyperproliferation of the bone marrow trying to compensate for the plasma cells being affected, that the immune system is like, I don't know what's going on. Let me try to overcome that. The amount of bone marrow activation is so high, and the amount of calcium that is leaving from the bone is so high that not only leaves that bone osteoporotic, but it's producing major lesions, which are called punch-like lesions, holes in your bones. How can you see that? X-ray.
And you look white, right?
Yes.
In the X-ray?
So lytic lesions in the bone. And of course, fractures. Now, even though they do have a translocation, ABL-CRL, fusion, the way we see this translocation, and this is also important, the way we see this translocation at the level of the protein chain reaction or electrophoresis is by looking at the M protein. So there's paraprotein translocation that is called M protein. So if you see that in any fluid or tissue, by biopsy, by CSF, if your presentation was neurologic and they do a lumbar puncture and they see the M protein, that's pathognomonic of multiple myeloma. Okay? So what else can be seen? Well, that M protein, when it's released through the urine, produces another sedimentation of paraprotein, which is called Benz-Jones protein, highly pathognomonic. So we have a lot of ways to diagnose this, even though the best and gold standard will be the bone marrow biopsy. The patient presents most commonly with renal symptoms, and you do a not regular urinalysis, like electrophoresis, right, of the urine. You're suspecting that this patient has multiple myeloma, and you see the Benz-Jones paraprotein present in the urine, multiple myeloma. If you do it in the electrophoresis of the blood or any other fluid, and protein. And of course, the gold standard will be bone marrow biopsy. But please, please, no the crab. Okay? And how do you treat this patient? Even though, again, bone marrow transplant is the curative, you also have induction therapy. Remember, tyrosine, proteasome inhibitors for induction. You could do plasmapheresis, and of course, the curative will be bone transplantation. Thank you for staying.
Thank you.